Good afternoon, everyone. I am going to present a rare case of bilateral posterior lenticonus. There is no financial interest. A 22-year-old male patient came to the IOPD with the diminution of vision both eye since childhood, but more worsened since 9 months. Patient was apparently less symptomatic 9 months ago. Then he developed slow progressive diminution of vision not associated with other symptoms. No any medical or surgical treatment history was there, and family history was also not relevant. On general examination, patient was well oriented with person, place and time, and rest other general examination and systemic examination was within normal limit. On ocular examination, unaided visual acuity was 6/60 and 6/36 in right and left eye respectively, and best corrected visual acuity was 6/24 in both eye. Eyelid and adductor, conjunctiva, cornea and the anterior chamber was within normal limit. There was an isocoria present, and lens having cataract changes of NS2 grade and posterior lenticonus was present in the both eye. Goldman applanation tonometry, intraocular pressure of the right eye was 12 mmHg and the left eye was 14 mmHg. On gonioscopic finding was normal and the fundus finding was within normal limit in both eye. On direct ophthalmoscopy, oil droplet sign was present in both eye. On retinoscopy, scissoring reflex was present in both eye. And ultrasound biomicroscopy suggestive of vitreous changes. Here the picture showing bilateral posterior lenticonus and cataract changes, and slit lamp examinations finding of the vitreous changes in both eye. On routine investigation, all the findings was within normal limit. My provisional diagnosis was bilateral posterior lenticonus with the cataract changes. Patient was operated for the right eye cataract with the SICS with IOL implantation. His best corrected visual acuity after 1 month was 6/6 in right eye, and the left eye was planned for the operation. Differential diagnosis includes lentiglobus, Loeys syndrome and Alport syndrome. Posterior lenticonus is a rare progressive disease characterized by protrusion of the posterior lens capsule along with the lens cortex into the vitreous cavity associated with local thinning or absence of the posterior lens capsule. More common than anterior lenticonus, but usually present unilaterally. Common cause of unilateral infantile cataract, but it is a very rare cause of bilateral cataract. Diagnosis is mainly clinical, but can be difficult in asymptomatic cases. It generally occurs sporadically, but familial cases have also been reported. In bilateral cases, X-linked and autosomal dominant inheritance have been reported. Prevalence is 1 to 4 cases for every 1 lakh children, and there is no sex predilection. Pathogenesis of posterior lenticonus is not very elusive, but various hypotheses have been postulated, like rupture of the posterior lens capsule resulting from highlight artery traction or trauma, congenital weakness of posterior capsule, aberrant hyperplasia of the subcapsular epithelium, disturbances in the tunica vascular lentis, and the vitritis or overgrowth of the posterior lens fibers. My conclusion is the present case may be a case of congenital bilateral lenticonus with the later development of the cataract in both eye with positive et al. Sign. Such case should be diagnosed as early as possible to prevent amblyopia and systemic complications. Treatment depends upon the age of the presentation, complaint, disease progression, and the systemic association. Thank you.
Thank you. Thank you so much.
What precautions did you take when you did the surgery? Because posterior lenticonus, always you'll have a PC dehiscence.
Yes,
So
ma'am.
any particular steps did you do different than what we do for pediatric eyes, which usually have this?
Mainly during the hydrodissection processes, there may be chances of the PC rent. So we take precaution during the hydrodissection. We didn't have hydrodissection. We proceed through the hydrodelineation process.
So you're saying it's a 22-year-old.
Yeah,
so
ma'am.
it must be there also long behind in the childhood. So what hydrodissection? Yes, you have not done. It's okay. But any other thing? Did your procedure change in any other way?
Ma'am, to rule out ma'am amblyopia, is there any amblyopia? Maybe present, but there was not amblyopia in the patient.
Any special for IOL power calculation?
What ma'am? Sorry.
Any special precaution for IOL power calculation?
Hello, we have got sufficient time, so discussion can be there. No hurry. So next presenter is ready.
Yes. Should I begin?
Yes, yes.
Good afternoon, everybody. It's warm inside and it's chilly outside. Hope we enjoy this session. Thank you, everybody here. And I begin with discussing with you some dangling lenses. There are a few points which we face every day, and these are simple takes which I would like to share with you. So sometimes the dangling lenses have the surgeon dangling also. So I would suggest that we would use the triamcinolone first. So if you have any doubt of a dangling lens, this is donesis or anything, and not the trypan blue, not jump first as we are taught to use the trypan blue. Let us see if I can stand my point. And I would like to discuss with you a little variation of the way I would love to put a CTR in these difficult situations. So here, as you could see, that it's a almost a matte cat we are tempted to put in trypan blue, but I put in triamcinolone to make sure that there is nothing coming out, there's no vitreous in the anterior chamber. And after that, I put in trypan blue. Am I correct? Should I be stopping in between? I say I am wrong. I should not have put in trypan blue just like that. We will see why. Sorry. Where is the bar? So after trypan blue, we go ahead with the rexis under high molecular weight viscoelastics as usual. A difficult rexis as usual because the zonular support is not there. Now this is the MST capsular hook, and we should better use the bimanual rotation technique. And you see here the leading eyelet of the CTR is being supported so that it does not go and abut at the equator of the already weak capsular bag. So here I have supported the outgoing CTR, and if you can lay your hands to this kind of a CTR injector, things are very simple. Not very simple, but easier. So now you remove under the cover of viscoelastics, remove the nucleus mass as usual. And as I said, I should not have put in trypan blue at that point of time because trypan blue has gone to the vitreous through that gap. So I should have plugged in that area with some high molecular viscoelastics before putting in the trypan blue. So trypan blue later, even after plugging that area. So I have lost the glow. Now placing this thing in the, and it's a bimanual is a better way instead of dialing it with one hand as we are used to. And I would prefer to place it in the sulcus. Now, everything done, though the glow is, I've lost the glow with trypan blue, and I check if there's any vitreous in the anterior chamber. Yes, there is some. So what to do? So I prefer to quench it at its source and not only remove it from the anterior chamber. So do a pars plana vitrectomy with irrigation in the anterior chamber. You can see. So quench the source from where it is coming and also remove it from the anterior chamber. That completes the procedure, so that causes better placement of the IOL. And check it finally with, and myose the pupil with trypan blue, pilocarpine. Now here we pre-plan with some kind of a scleral support is necessary. So a scleral pocket is made beforehand, and standard cataract, and check it with, now I place viscoelastic here so that everything is, I can have the vitreous from prolapsing. It's difficult rexis, there's no need of trypan blue here. Go ahead with the rexis, use an MST hook, which gives a better support of the equator of the dangling lens. Again, I prefer to put in the CTR with a support of the allow the leading eyelet to carousal at the tip of a ball dialer maybe, or a Sinskey hook, and then let it go at the opportune moment when it is required. And slowly, this I think would exert lesser pressure on the existing zonules. Now you place an iris hook 2 millimeter from the limbus, so ciliary sulcus area. There is chance of bleeding because this is a blind procedure. So you go ahead here, railroad it out, or there is bleeding, and pass it through the eyelet of a Sioni segment, almond segment, and then through the scleral bed, again railroad it back. And fix it on the scleral bed, and negotiate the Ahmed segment CTR to the equator of the capsular bag, and titrate the pull and place it and center the bag as much as practicable. And the knot is placed below the scleral flap and cover it with the scleral flaps. CTR is, the IOL is again placed in the sulcus. So here also that kind of a case. So I prefer, instead of using trypan blue, I use triamcinolone, which makes it very much evident that there is so much of vitreous. Now it's a blind procedure through a pars plana. I mark the cutter how far I can go because it's a blind procedure. So I won't go beyond that. With irrigation in the anterior chamber, so there's tamponade in the anterior chamber, and I do pars plana vitrectomy. That through the zonules, it goes back, through the torn zonules, it goes back, and it is removed from where it has been coming. That makes things simpler for the cataract to proceed with the cataract. Thank you so much. And then you do a trypan blue staining.
I think it was a wonderful video and very much innovative idea what you have used, because vitreous in AC most of the times may not be tackled in a nice way
because we mess up
before
with it.
proceeding further.
So it's a lesson learned after a long time. So I've been messing it up for 10 years, and then I thought that why not stain it with trypan blue. That's a very favorite molecule of mine, and this is not the place maybe, but I also leave a little bit of triamcinolone at the end of all surgeries in the anterior chamber. Not only wash it away, leave a little bit. That takes care of the postoperative inflammation for about 10 days.
Pushing triamcinolone before trypan blue is a great idea, and that way you can identify the
It is nothing great
vitreous.
idea. It's just a thought I'm sharing with whosoever would like to use it. I think it is not a big thing. You don't need investment, but it's just a thought.
Only the thing is, when do you initiate that thinking process that this lens is not the normal lens? Whenever there is a borderline lens, little bit odd lens.
Yes, it's tremulousness. When you, even if you have started with the visco, if you find that the moment you start rexis, you have folds in the anterior capsule. That means the zonular support is not there. Try to use trypan blue. Even with a visco, that will show up. But one more thing I could not show you, it does not show up at one go, because there is a barrier. It comes out with what, but you will see that that particular area triamcinolone has not been able to reach. So you inject it once more, then it stands up.
Visco, then
You can, but it's difficult. But
You are anterior segment surgeon or VR surgeon also?
I'm an anterior segment surgeon.
Because in that case, suppose VR is to be tackled, do you have some backup VR surgeon?
Yes, in the next OT, the VR surgeon is
Because
there.
for routine general ophthalmologist, when person is anterior segment surgeon and some help is needed by vitreoretinal colleague, so in that case, what is to be done? That was my query.
what I am suggesting, because nowadays most of the anterior segment surgeons, they know little bit of VR, little bit, just by going by
anterior segment machines come with
yes,
5,000
yes.
cut rate.
Because nowadays what we do that there are 2-3 VR surgeons, but they are busy in their long OTs. So the anterior segment surgeons should have that much of training at least, that if there is any problem, they can go by to pars plana route even not by the trocar cannula, but by 33 gauge. This is 23 gauge.
The suture that is suture
and it is
scleral
self-sealing.
wound.
It is self-sealing, and we can do it.
We can do it. It's not a big deal. It's just a thought which you have to put in if it is
Yes.
available, and
Yes.
you must have the courage to do
Yes,
it. It is not a big
much
deal.
anterior segment
Everybody
surgeon
can do
do.
it. Everybody
So
can do
it's
it.
not a big ILM
Right.
peeling. It's just a just a core thing, and we can do it.
Yes, the
And
machines
many
come
of
with
us
it.
are doing it.
Machines come with it. We are supposed to be
But
done.
your
That's why
idea
they are
is very
giving
nice
it now.
that you are putting tricot and not.
Then trimethylene. I think in the audience,
so
most
much.
of the ophthalmic surgeons may not be knowing this technique. And to start with, not with trypan blue, but triamcinolone is the wonderful concept. And in your cases of little bit complicated cataracts, you must use that technique. I think such type of innovative presentations are expected in the conference. And the take-home message by the talks like this must be taken by the delegates. Thank you. Thank you so much.
Thank you so much,
So
sir.
one question.
Yes.
So it's beautiful things which you had shown, and we have any cases where we are thinking that there can be a vitreous, we should always put on triamcinolone.
No
and,
harm.
Yeah, no harm in putting, and even like that case you saw, you did it in the posted by putting a tricard, but also we can go through anterior, take out the vitreous which is there, then again stain it the anterior capsule, and then again go about doing the thing. So that is what is a thing, but you showed it beautifully. How can you take it
Not
back?
all
Yeah.
not all the things will go that beautifully.
That beautifully.
But
But
this happens.
it
At
happens.
least part of it will happen.
Yeah, so the message is very good, so we should put on any
Because
cases.
Dr. Vasavada has
Yes.
showcased us and taught us that you should quench it from where it is coming.
Yeah.
You can't do it from anterior.
Yeah.
But you can, we try. Limbal route is also welcome, but
And
sometimes it does not
Yeah,
happen.
the more you take, it comes up, but
It keeps
otherwise
coming.
it goes
It
back
keeps
in a
coming.
shrinking. That is a good idea.
And I maintain the irrigation tamponade in the anterior
Yeah,
chamber.
yeah.
That,
Those three things are very important. Put the triamcinolone on, and then you can actually coat it with high viscoelastic that area,
Right.
and then you can stain the anterior capsule in a white cataract to do your excess.
Right,
So
thank
these
you
are
so
very
much.
important points to be taken.
Right.
Thank you, sir.
Thank you so much. Now the next presenter. Is the presenter ready? Yeah.
A very good
Introduce
afternoon.
yourself and on whose behalf you are
Yes, yes.
present. Yes.
Good afternoon, everyone. The topic of the presentation is anterior capsular bulging sign and flat cataract sign, the two diagnostic signs of lens coloboma. The chief author is Dr. Parthasarathi Roy, and I am Dr. Millie Mandal, Junior Assistant, Calcutta National Medical College. I'll be presenting on his behalf. Eye surgeons need to be familiar with the presentation of lens coloboma in order that they can better plan a cataract surgery on a colobomatous eye. Our objective is to present two new diagnostic signs of lens coloboma on slit lamp examination. To the best of our knowledge, there is no telltale diagnostics clinical sign for the diagnosis of lens coloboma, or the zonular coloboma to be precise, till date. And ours are the first such diagnostic signs. So here we are presenting a case of a non-diabetic, non-hypertensive male patient, age 63 years, presented with dimness of vision in the right eye since childhood. His vision started to deteriorate 4 to 5 years back when he noticed something white in his eye. On examination, the right eye showed a BCVA of 6/36 and an NCT of 18 mmHg. We found an infranasal coloboma of iris and a pie of white cataract in the colobomatous area, with an amber to black nuclear sclerosis elsewhere in the lens, which we termed as flat cataract or double cataract. So here we can see that in the right eye, there is an infranasal coloboma of iris and a pie of white cataract in the colobomatous area, with an amber to black nuclear sclerosis elsewhere in the lens. So on slit lamp examination, anterior capsule was seen to be bulged anteriorly in the colobomatous area, which is the anterior capsular bulging sign, with cortical matter also followed the capsular bulging. Through the cataractus lens, we found a fundal coloboma. It was also noticed in the indirect ophthalmoscopy, and the left eye was within normal limits. On slit lamp examination, the anterior capsule was seen to be bulged anteriorly in the colobomatous area, with the cortical matter also following the capsular bulging. Coming to the discussion and conclusion, the term coloboma of lens is a misnomer. It is actually zonular coloboma. In the area of zonular coloboma, the zonules are either weak or absent. Relieved by the pull of zonules, the elastic anterior capsule bulges forward, which in turn gives rise to this anterior capsular bulging sign. And as this change in the capsular shape, it occurs very early in life, the plastic lens matter, which lies underneath, also bulges forward. So due to this difference in the architecture of the lens, the two types of cataracts, they develop in the colobomatous area and elsewhere in the lens, respectively. Although some schools depict the notch in the extreme periphery of the lens as coloboma, this actually represents the depression below the bulged anterior capsule and not the true notch in the lens. So hence, this can be called a pseudocoloboma of lens. So this is the picture where they're showing that this is actually the superior lens notch, which is visible in the retroillumination. But if we do a slit lamp or the oblique section, optical section, we will get to see that there is an underlying defect, which in turn results due to the anterior bulging of the lens and not due to the defect of the lens matter. With this, I would like to conclude that the only real valuable thing is intuition. The intellect has little to do on the road to discovery. Thank you.
You are saying slit lamp, we can always see it. Is any other thing now coming up we have with us? We can also find the coloboma, or we can see the anterior capsular bulging. We have so much armatorium with
segment,
us. Any other things through which we can also know it?
Anterior segment OCT, ma'am?
Yeah, so that also can help us.
Yes. Yes.
So what more exactly you wanted to see us through slit lamp? We always examine and we get to know. So what is your message which you want to give in this?
Ma'am, the basic message that we want to give in this is that it's very important to identify the colobomatous lens, and this is a sign where we are saying that it is not due to the zonular deficit, it is due to the lens capsule bulging. So this is a sign which will help us to identify and detect lens coloboma on slit lamp examination, which in turn is going to help us in planning these cases beforehand for the surgery.
What, because lens coloboma, we anyway get to know it. So what other thing will this add to us? That is what. Surgically, anyway, we know this is a lens coloboma and we are going to go about with our surgical technique. Yes. So this finding which you are saying, what extra is it adding to your literature or to our study, or how do we handle differently? That is what I just wanted to know.
Ma'am, management is definitely not going to be different per se.
Okay.
Okay, thank you. Thank you so much.
Thank you.
Now the star presenter, Dr. Sugata Paul, my friend, will be speaking on Bold from the Blue.
No,
The
don't
time
start
is yours. There is no limit of timing,
Don't
sir.
start the presentation, yeah. So I'll be presenting a surgical video which I have named Bold from the Blue. Bold from the Blue means something happening unexpectedly, and that the video will show what happened unexpectedly in the first few seconds. So don't move your eyes off the video for the first few seconds, and then you can take a nap, because the management you all will be able to manage. So I'll show what happened and how I managed. So this starts. So I'm putting the visco in a straightforward cataract. The visco, and you can see, I'll stop there, you can see it just jumped, the cannula just jumped from the thing. I was using a Liverleaf cannula. In spite of that, it came out and it just hit the iris. And then what to do? So I switched on the thing, Lumeri retroillumination to assess the injury, and there is an injury there, which is an extension, and what to do next. So it depends on the surgeon's expertise, the grade of the nucleus, the comorbidity, and whatever you do, If you plan to do phaco, what you do? You have to do minimal hydrodissection and nucleus rotation, maintain minimum lateral separation, work away from the tear, try to do anterior planar phaco, maintain the anterior chamber, and look for Rohit PRAKASH sign, which is wrap-up sign, and always have a plan B. So here I decided to go ahead with the phaco. I have already shown you the extension from 1 o'clock to 7 o'clock. So whatever you do, you need to have a good access to the nucleus. So I have nicked the anterior capsule, which was extended, and with the help of Haldiputkar forceps, I am doing a hemirexis on that side. So once the hemirexis in one side is done, now I have to do the rexis on that side. Here I am nicking with a 26G needle because of the location of the extension. It is difficult to use venous scissor there, so I am nicking with the 26G needle, and then I am doing the hemirexis. So now I have a good access to the nucleus to do the phaco. And as I have said, if anything goes wrong, you have to give away your ego and convert to SICS or extracapsular at any point. So once this is done, you have to do minimal hydrodissection, and note how I am rotating the nucleus. I am using two hooks to rotate so that no pressure is put on the zonule. And while doing the phaco, as you see, I am working away from the extension. The extension was at 7 o'clock, and 1 o'clock I am doing the phaco at about 4 o'clock position. I am putting my phaco tip. And while rotating the nucleus, I am rotating it against the phaco tip. So the phaco tip is working as the hinge for the rotation of the nucleus. So this is the third tip. So rotate as a hinge, I am using the phaco tip. And once the small pieces of chopping is done, then the job becomes easy. So very slowly and very gently, you can see I am using moderate speed for doing the phaco, and once the nucleus are chopped, you can bring it in the anterior planar and emulsify the small pieces as I am showing it now. So once this is done, almost 90% of your job is done. Now while doing the IA, don't take away the phaco tip. So rest 10% can give you trouble if you don't maintain your chamber. So what I am doing, I am putting viscoelastic before taking the phaco tip out to form the chamber, and then going for irrigation and aspiration. While doing irrigation aspiration in these cases, be careful you are not pulling the torn part of the anterior capsule, so you have to careful move it in a sideways, bring it in the center and do the IA. And then you can see the hemirexis, put the lens or dial the lens in such a position that it's placed in the hemirexis. Unfortunately, during that time, the 3-piece IOL there was some shortage of the Johnson & Johnson 3-piece IOL. So otherwise, I would have put a 3-piece IOL on the sulcus, but it went on fine. So all well, that ends well, and I did wound hydration to close the wound. Thank you.
I think it was wonderful video. Ma'am, your comments, please.
So it's a beautiful surgery which you have shown, and we usually encounter this. Yes. So you had a tear at both the ends, and managing that tear to make it as semicircle, that is a good thing, and also putting it in the bag. A single piece you have, even though we don't have a 3-piece, also a single piece can be put in the bag, which is the most important thing. The thing is, you got the rexis, and we can do also a smaller rexis and keep on doing the cataract. But only the thing is, if you have a very dense cataract, maybe we'll have difficulty. Otherwise, soft cataract we usually go about. So that is the main
normally when you get Argentine flag sign, it's normally located 3 to 9, means perpendicular our phaco plane, but this was almost parallel to the phaco plane, which made it difficult, but it went on well.
So complications do occur.
Yes.
So it is a surgeon's skill how to handle that.
This is something, as you said, I was using a dual loop cannula which is locked, but still the cannula came out. I think probably the nurses didn't tighten it properly, and it just came out like a jet hitting the lens capsule and just producing the...
so this is something also to be taken care of. So we usually just...
I do put my finger, and in spite of that it went out.
Also do the same. Sometimes it happens with everyone.
Yeah.
And we convert it, the C shape, what you did.
Thank you. Thank you.
Thank you so much. Yeah. Next presenter.
Okay, so everything is done. So that case is this is the bold thing that we all do the same, and that case was a unique presentation that dangling lens and putting tricot before the trip and blue. So we have already discussed.
Is Dr. Mohammad Dayan here? Next presenter. No?
Yeah, please conclude.
So we are coming to the end of this session. Thank you so much, all the presenters. They were very good presenters, and hope the audience gets benefited by their presentations. Thank you, all of you. And on behalf of my chairpersons, I thank all the organizers for giving us the opportunity. Thank you so much. If the speakers are there, they can come here for group photo. एक मिनट बैठो मैडम, he is taking photo. Hello.